When they enter perimenopause and menopause, many women living with MS face uncertainty, wondering how these phases of life might impact their disease. Welcome to Ask an MS Expert. I'm John Strum, your moderator and host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years. So I've had a front row seat experiencing all the ways that MS can impact a family. Today, I'll be asking our expert the questions you want answered. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS Navigators will be online throughout today's live program, answering your questions and connecting you to resources. Perimenopause and menopause can present challenges that affect a woman's daily life and well-being. Dr. Riley Bove, a neurologist, researcher, and associate professor at UCSF Health in San Francisco, is joining us today to discuss how to best manage those challenges. In her practice, Dr. Bove works with individuals living with MS. She's written several articles about how hormones impact MS and other neurological conditions, and Dr. Bove has a special interest in women's health from pregnancy through menopause. Dr. Bove holds relationships with a commercial interest through grants and research support received from Eli Lilly, Biogen, Novartis, Roche Genentech, Alexion, Amgen, Cadenza, EMD Serono, and Sanofi. Welcome, Dr. Bove. Thanks for being with us today.
Hi, John. It's my pleasure.
You know, this is such an important topic. Women who are experiencing perimenopause and menopause make up about 30% of the MS population. So I hope you'll start us off by explaining what each of these terms means and then explain the differences between these two phases of a woman's life.
Great. Yeah. So if we think about a woman's life, you really have the sort of prepubertal phase, and then you have the reproductive phase. When the menses end, that is menopause, and then you have the postmenopausal phase. When we're talking about menopause in women, we're actually need to distinguish what happens around the time of the final menstrual period. So that's the perimenopause, and then what happens later on in the postmenopausal lifespan. So in the few years coming up to the final menstrual period, and a few years after the final menstrual period, that's really the perimenopausal transition. And during that phase of life, women may experience a number of symptoms. They'll experience changing hormone levels. They'll experience changes in their menstrual cycles, which can become more frequent until they peter out and eventually stop. They could also experience changes in their mood, their cognition, their sleep, hot flashes, etc. So a lot of the times when we're talking about menopause, we're talking about that perimenopause, that transition period. We also have to think about wellness of women during the 20, 30, 40 plus years that they may live postmenopausally, so that we're really thinking about set them up well for sort of healthy aging in that postmenopausal lifespan. So I think it's helpful to really distinguish those two phases and then kind of sort of target the conversation around, which one we're talking about.
Many symptoms of perimenopause can mimic symptoms of MS. Can you talk about those particular symptoms?
That is a key point here. So during perimenopause, again, women can experience vasomotor symptoms, hot flashes, feeling of palpitations, things like that. They can also experience disruptions in their sleep, disruptions in their energy, in their cognition, in their mood, in their libido. All of those things happen during perimenopause. All of those things can be worsened by the hot flashes, and many of those things sound a lot like MS symptoms. And so what I commonly hear from my patients is, I don't know if it's my MS or my menopause or both. That's one of the most common things that they say during this time, because there is such an overlap in symptomatology.
And is there anything a woman can do to better understand what the root cause is of the things she's experiencing?
Yeah, I think this is really a yes and kind of situation where we think, yes, a lot of this sounds a lot like your menopausal transition. And a lot of it sounds like all of this is making your underlying MS symptoms kind of flare up, feel worse. And so, what I like to really advocate for my patients is that we have a very comprehensive approach here. I don't want to sort of say, well, this is mostly, your menopause, go off and see your PCP, or this is all related to your MS getting worse. Often it's just sort of during this period, people feel worse because of this. And so I think just thinking very practically and pragmatically, I think it's, worthwhile to see people a little more common, more frequently, and to then just sort of like really think through each symptom. How are the hot flashes affecting this? What is sort of typical of a bad MS day and what feels different?
How might perimenopause and menopause impact actual MS progression?
Yeah, great question. So I think there's a few mechanisms that we have to think about when we think about MS progression. So one is if someone is feeling worse during perimenopause, whether or not that's related to their MS at all. If they're feeling worse because they're not sleeping as well from the hot flashes, they're experiencing some worsening in their bladder symptoms from the genitourinary syndrome of menopause, they have some joint pains because, again, when estrogen levels decline, there could be those kinds of symptoms, shoulder aches, knee aches, etc. If they're experiencing all of these symptoms, they're going to be less likely to do the things that keep their MS well. So they may not exercise as much, they may not sleep as well, they may, they may sort of go to more snack foods or sort of like comfort foods. They may change their behavior in a way that could make their general wellness worse and their MS worse. Um, the other piece here is they may or may not take hormone therapy, and that is its own sort of ongoing work to try to understand how hormone therapy plays into MS. And then the other piece is if you separate out sort of the layers of behavioral change that happen with the menopausal transition, the layers of the general wellness changes that happen with the menopausal transition. So again, changes in sleep, changes in activity patterns, changes in risk of diabetes, high lipids, so cholesterol, all of those things. If you tease those out, and you just look at the impact of menopause on MS worsening, we do see a little bit of worsening postmenopausally, more than we might just expect for age, but that is actually slight. It's more the comorbidities, more the behavior, more the self-management and experience that I think is more relevant to the conversation than perhaps just the slight worsening in underlying nerve function.
A change in hormone levels, specifically estrogen, that's the main culprit behind most perimenopause symptoms. What is the role of estrogen, and why is the loss of this hormone significant for women?
Yeah. So the ovaries produce estrogen. They also produce testosterone, which is an interesting fact, which I actually never learned in medical school. And testosterone also has important biological effects in women. So certainly sort of, muscle, energy, libido, things like that. But if we focus on estrogen, which is sort of the major change that happens postmenopausally, we know from the animal models, so the mice models, that other animals that we use in research, we know that estrogen has really, really important effects in many tissues, from bone to sort of heart and blood vessels to brain. And when you lose, and so estrogen has many effects, sort of protective effects on sort of the body and the brain. Estrogen, of course, is also probably linked to risk of relapses and inflammation in women with MS, right? So estrogen has, maybe sort of inflammatory or um, it can modulate immune attacks in some ways that are still kind of being worked out in human women. And it also has potentially neuroprotective effects. And so in someone with MS, you're kind of trying to toggle. So what's the effect of estrogen on immune activity? What's the effect of estrogen on neuroprotection, brain resilience? And how do we sort of calibrate all of this? So practically speaking, when you have the loss of estrogen that comes with menopause, interestingly, we do see lower relapse rates in postmenopausal women. But again, we see a slight worsening in neurologic function. And so we assume that that's because of the loss of estrogen. It hasn't been sort of definitively proven that it's just estrogen, because again, there's a lot of other hormones that could be at play.
Perimenopause can be both confusing and frustrating for many women. So, when is the best time for a woman to begin discussing her symptoms of perimenopause with her care provider?
Great question. So, what we want to avoid is a situation where a woman comes in, fully with hot flashes and really feeling quite upset and, sort of, wow, I thought my MS was controlled and it's not. And what is all this? And am I progressing? We want to avoid the situation where people come in just feeling like they've fallen off a symptom cliff. Okay. Because so many of these symptoms are very treatable, very manageable, and sometimes even preventable. And so what I try to recommend, we don't know exactly when someone's going to go through their menopause. There's a lot of variation. And also there's a lot of variation in what symptoms someone is going to experience. And so because of that, I think a reasonable rule of thumb is that starting at age 45, that might be when the neurologic team kind of puts on the map for the patient, hey, it may not happen for another 5, 10 years, but just so you know, you may start experiencing these things. And I want you to come to me so we can start, parsing these out and reducing their impact on your well-being. So I think a reasonable rule of thumb is 45. Again, there's no rule that everybody is going to get these things. It's just that we want to avoid the situation where it just hits the person and they feel worse.
Rachel says she was diagnosed with MS in her late 30s. Now at 47, she's noticed that her menstrual cycles become very irregular, sometimes skipping several months. Her gynecologist suggested checking her hormone levels and sent her for blood work. Can a blood test tell if Rachel is in menopause?
Great question. So there are several blood tests that can be really indicative in this situation. So what we see is when the follicles in the ovaries, when the eggs basically start to really decrease, we see a change in a hormone called anti-Müllerian hormone, or AMH. And AMH is basically a blood test that tells us, hey, the ovarian reserve is really declining. When those follicles decrease, then you're not getting the estrogen increase from the ovaries. And so estrogen levels can sort of be variable. That signals to the brain. The brain says, hey, ovaries, I'm not seeing the hormones I would expect. So I'm going to send you more FSH, follicle stimulating hormone. So you see the FSH levels rise because that's a hormone from the brain that's telling the ovaries, hey, can we increase the estrogen here? And so when you look at the blood levels in a patient, you'll see decrease in AMH. The estrogens kind of be, maybe all over the place. And then the FSH is going to start rising. And when the FSH rises above a threshold, that really gives us a sense that the person is, nearing that final menstrual period.
Selena was diagnosed with MS in her 20s. Over the course of her adult life, she says that she's often taken steroids to treat her MS symptoms. What special considerations do women living with MS need to be aware of when it comes to chronic steroid use?
Yeah, regarding chronic steroid use, in the past, we wondered whether steroids affected, the menstrual cycle or fertility or things like that. I think a lot of our patients today don't use steroids to the extent that we would see that. What we do worry about are whether Selena's going to be at a higher risk of bone density loss, so osteopenia, osteoporosis, and also whether she's going to be at any elevated risk in terms of sort of prediabetes, so hyperglycemia, hemoglobin A1C, diabetes. And so a lot of times we recommend typically bone density screening happens after the age of 60, but it can be performed starting at age 50 in higher risk individuals. And so for me, I would rather know that a person's bone density is low and take measures to try to prevent that loss as much as possible with, calcium, vitamin D, and with some of the medications available. So I would rather know that. And so I tend to recommend that my patients, especially who may be at risk from steroids like Selena, get bone density testing sort of as a high risk group at age 50, and then kind of follow up with their primary care or endocrinologist to figure out what to do if there is bone density loss.
Roberta lives with MS and she takes an antidepressant drug along with her disease modifying therapy. So Roberta went through menopause at the age of 51. Now she's 52 and she's noticed that she feels sad most of the time. And she's also experiencing extreme mood changes. Now, Roberta doesn't think she should bring this up to her MS specialist because, after all, she's already taking an antidepressant. What advice would you share with Roberta about these mood changes and what she might be sharing with her MS specialist?
Yeah. Yeah, I think there are many things that contribute to low mood, and there are many ways of tackling low mood. So just because Roberta already carries a diagnosis of depression and is on an antidepressant doesn't mean that she isn't experiencing legitimate change in her well-being, worsening in her function that merits treatment. Because we have to recognize that an antidepressant and one specific one at one specific dose isn't the be all and end all here. So I think, recognizing where Roberta is in her life in general, how is she feeling about her MS? How is she feeling about her home life, her partner, if she has one, her family? How does she feel about, her job? Is she going through empty nest syndrome? Does she have other medical conditions like thyroid disease? Thyroid changes are so common in the general population, and they can also contribute to some of these symptoms. So really, I think it's worth taking a step back and mentioning this to her neurologist and her primary care doctor, because there are so many other things that could be contributing to the low mood and that could also be treatable. You don't want to miss a medical condition. You don't want to miss, an opportunity to sort of receive talk therapy or to think critically about, your home life, right? So these are all other things. And so then the intervention may be increasing her antidepressant dose, but it may also be changing medications. It may also be getting more social support, joining a support group, doing more talk therapy or mindfulness exercises. It may be a lot of other things to really have a comprehensive, multi-pronged, and really personalized approach to how Roberta is feeling. And so just because she's on a medicine doesn't mean that she shouldn't bring up her experiences and suffering with her care team and get other solutions.
Are there other complications that may occur during these phases of a woman's life that are perhaps less well known?
Many things remain unwell known. So sort of, so how is sleep affecting everything, right? Is sleep affected just because of brain changes, or is sleep, affected by the hot flashes? Like, how do we tackle something as complex as sleep? Another one that I hear commonly from my patients and that is not well described in the medical literature are joint pains. So a lot of women who go through menopause talk about pains in their joints and their ligaments, their muscles feel more tense, etc. And there's specific things like pain in the shoulder, frozen shoulder, that's very, very commonly reported by patients, and it's not well known in the literature. And so you can guess that people aren't screening for shoulder pain and thinking about, wow, well, if you have painful shoulders, maybe you're not exercising as much or sleeping as well, etc. And then, I think one that, we want to talk about a lot also is just the hot flashes. So hot flashes are so common. They're very different by sort of individual society and culture. So they're not universally experienced. There's some really cool anthropological studies that suggest that Japanese women, for instance, may not have as many hot flashes. Um, but for people with MS, not only can hot flashes wreak havoc on everything, but as you well know, there's a Uthoff's phenomenon where heat makes MS symptoms worse. It doesn't injure the nerve, but while the person is hot, they feel worse. And so, just we don't understand whether the hot flashes in particular result in Uthoff's phenomenon, because Uthoff's is poorly measured by like tests. But it makes a lot of sense from an experiential standpoint that when people are cycling through hot flashes multiple times a day, they're feeling worse function in terms of, visual blurring or nerves tingling, et cetera.
Menopause typically impacts three areas of women's health: reproductive health, immunology, and neurological health. What are the most common medical treatments given to women to treat symptoms during this phase in their life?
Yeah. So, one of the key things is just handling the symptoms themselves so that they don't have snowballing effects. Okay. So, in terms of reproductive health, I think we want to just, again, tackle any vasomotor symptoms through HRT or otherwise, and we can talk more about that. And then making sure that women have all of the gynecological care that they need. So there can be the genitourinary syndrome of menopause, where women experience, more sort of vaginal symptoms, dryness, atrophy, et cetera, and bladder symptoms. So that can be handled with medication and different treatments. From an immunological standpoint, we see two things. We see that perhaps the risk of relapses decreases. We also see a higher risk of infections. And so, we certainly saw this with COVID and just sort of like general aging, is there is a higher risk of infections. And so we want to toggle from an immunological health standpoint. We want to think about what is the patient's risk for relapses and what are the potential infectious complications of their drug, so that we maybe recalibrate the immunological health differently. And then from a neurological health standpoint, we have to think about the impact of all of that perimenopausal symptomatology on brain wellness. So how are you expected to be alert and thinking straight on your job when you haven't slept and you don't feel well, et cetera? And also, over time, are there actually brain changes, loss of neurons, loss of axons in response to menopause? So I think in each bucket, the reproductive gynecologic bucket, the immunological bucket, and the neurological bucket, we want to really think about what is preventable, what is manageable, so that we can really optimize a woman's health.
I'm glad you mentioned HRT. Hormone replacement therapy is a well known treatment for the symptoms of perimenopause. Is that a good option for a woman who also lives with MS?
We are in a societal gap moment around this. Okay, so about 20 years ago or such, this massive women's health initiative study designed to really demonstrate that HRT, sort of did a lot of good things, had to be stopped because there were concerns about actually side effects and risks in women. So everything stopped. Research stopped. Education about HRT stopped. And so what we have today is a whole generation of doctors, nurses, all of the medical personnel who really have not been trained in HRT at all. And then we also have a situation where people have reanalyzed those data And when you reanalyze the data, you really see that HRT, when you gave it to women in their 50s, actually had a lot of benefits. So including all-cause mortality, cancer risk, etc. And so we're now in a situation where women who are going through menopause are saying, hey, actually, this isn't bad for me. It's even good for me. So what can my doctor do? And you have doctors who say, we don't know, we don't have training. And so there's actually a whole cottage industry that's been set up around this theme to try to provide evidence-based answers for women. So what women can do. So hormone replacement therapy for many women, except those at high risk for certain cancers, so breast cancer, and those at high risk for clotting. So women who may be more immobile, who may be, less likely to move around and keep their blood flowing. For those women, HRT carries more risks. For the other women, HRT typically is considered beneficial. And so it can be given to treat the menopausal hot flash symptoms, quality of life, prevent bladder changes, prevent bone density loss. So those are all ways in which HRT can be beneficial. What we don't know is whether using HRT during the menopausal transition translates into better brain health 10, 15, 20 years down the line. We don't have the perfect data for that yet.
I actually heard you begin to answer this question a few moments ago. I want to circle back to it. We know one of the potential benefits of disease modifying therapies is improved health outcomes. What do women living with MS need to understand about how life post menopause may impact their symptoms or the progression of their MS?
Mhm. I think when we think about a woman's long-term health outcomes, one of the important things is that she has engagement with an internist, a primary care doctor, who is going to work to maintain her health. For a lot of years, women with MS see their neurologist. And it's already so burdensome to get the neurologist, get to the MRIs, get the labs, get the meds, etc., that there may be things about general wellness that fall by the wayside. And so for me, the menopausal transition is a really good time to re-engage on general wellness and say, okay, we need to tackle the symptoms you have right now. And we need for you to be engaged with a primary care doctor who's going to be comprehensively looking at your health down the road, not saying that everything is MS, but looking at things like thyroid disease, like gynecological health. Could it be that the immune medications you're on are affecting your gynecological health? Needing regular pap smears, things like that, mammograms. So we want our patients to do all the age appropriate cancer screens, checking in with the cardiometabolic things. So high blood pressure, is the sugar well controlled? Are the lipids, cholesterol well controlled? All of those lines of things. And then really, I think, re-engaging with rehabilitation professionals. So are you walking as much as you could be? Yes, you may not be able to walk 10,000 steps because you have, a foot drop or such, but are you walking as well as you could? Do you have the right devices, etc.? This is all sort of generally part of healthy aging, but it's really important for our patients with MS during the midlife to re-engage with all of these factors because we can really help prop people up for well-being and healthy aging.
Well, you've shared some really helpful and important insights about the relationship between menopause and MS. What would you say is the top takeaway that you'd like our viewers to remember and to use?
Yeah, I'd like our viewers to really know that the perimenopausal window is a window of opportunity, okay, where we can really take on how you're doing. We can really recalibrate things and help to set you up for healthy aging. So much of the conversation around menopause is one of sort of despair. Oh, I'm going to feel terrible, and then things are going to get worse. And really, we can help you feel so much better. There are medications for the hot flashes. If not HRT, there are other ones. There are alternative therapies. We can do so much to help you feel better and to prevent worsening, that I think this is actually a really critical time not to despair, but to re-engage and to think positively about the future and plan for it.
Well, I want to thank you for being with us today, Dr. Bove.
It's my pleasure. Thank you.
Today's program survey has now been posted in the chat for your feedback. Please take a minute and complete it to help us create programs and topics with you in mind. Please be sure to visit the MS Society's website for information and resources on MS, connection opportunities, and ways for you to get involved. You can also connect with an MS navigator to receive personalized support by phone, email, or through the Society's website by chat. A recording of today's program will be posted on the MS Society's website at nationalmssociety.org/msexpert, as well as on Facebook and YouTube. Finally, I'll invite you to join me each week on the Real Talk MS podcast, where we continue the conversation that we start here. You can find Real Talk MS on Apple Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. Thanks for joining us for Ask an MS Expert. We'll see you next week.